Hi, I'm Richard Finn from the Geffen School of Medicine at UCLA. I'm joined today here at the San Antonio Breast Cancer Symposium 2016 in this special eCancer video highlighting cyclin-dependent kinase 4/6 inhibitors and their role in breast cancer. I'm joined today by Dr. Mark Harries from the United Kingdom, Dr. Sandra Swain from Georgetown University, and Dr. Michael Gnant from the University of Vienna. Today we'll be discussing various aspects of CDK4/6 biology and how it is impacting our management of women with advanced breast cancer. If we take a step back and look at the development of CDK4/6 inhibitors, they've followed a very rational development program over the past several years. The biology of cyclin-dependent kinases has been known for a very long time. The Nobel Prize in 2001 being awarded to the investigators that identified the key regulatory machinery that was important in cell cycle regulation. And very early on, it was identified that dysregulation of the cell cycle can lead to cancer. The hunt was then on for various ways to target this pathway, and it's only in the past 5-10 years that we've had very specific inhibitors of cyclin-dependent kinases. CDK4/6 specifically has now 3 clinical grade compounds that are some approved or close to being approved, including palbociclib and ribociclib, as well as abemaciclib, which is still in late phase development. But needless to say, all of these have shown some preliminary evidence of activity in ER-positive breast cancer. And the reason for that, I think, goes back to some preclinical work that I was involved with Dennis Slayman and collaborators at Pfizer that identified a dependence for ER-positive breast cancer on CDK4/6 inhibition, and in that context of that work with palbociclib, as well as its ability to inhibit cell growth in combination with endocrine therapy and to have some ability against models of endocrine resistance. With all that in mind, several clinical studies have been launched, and we'll talk about the results of some of that data now. So Mark, could you give us some perspective on the current phase 3 studies and in development in this space?
Thank you, Richard. Yes, I mean, it's an exciting time to be in this area, isn't it, with these results that have been published over the last year or so. And I'm just going to highlight really probably 2 of the trials, I think, for the time being. One is called the PALOMA-2 trial, and a similar trial called the MONALEESA-2 trial, and I'll probably mention one of the other PALOMA trials. So if we start off with the PALOMA-2 trial, first of all, this was a first-line metastatic study for women with ER-positive breast cancer, in which they were randomized to receive either just letrozole on its own or letrozole plus palbociclib. And I think what all took us aback was the degree of benefit that was seen, with the headline being a significant improvement in progression-free survival, taking the median from 14 months or thereabouts up to 24 months, which was really, I think, for the community, quite a stunning result, I would say. And then hot on the sort of the heels of this was a similar trial, very, very similar design, I would say, similar number of patients, about 600 patients, but this time using the other cyclin CD4/6 inhibitor, ribociclib, and again a very similar degree of benefit, again with women staying on treatment for a significant extra period of time if they were randomized to receive the cyclin inhibitor. Both of these studies are very well conducted, big trials, so I think we have little doubt that there is real clinical utility in this area. Just one footnote that we now also have data with palbociclib with other compounds, so not just with the aromatase inhibitor. There's a study called the PALOMA-3 trial, again a randomized trial in which the backbone was fulvestrant, a selective estrogen receptor modulator, dysregulator, and again showing additional benefit for women who received the palbociclib in addition to that. So I think we have drugs that are really active as evidenced by these clinical trials.
Yes, it certainly is a very exciting time. I think this efficacy obviously needs to be weighed against any toxicity. Sandra, could you give us some insight into how you see the toxicity of palbociclib and ribociclib? And then if you could also comment on abemaciclib, which I know you've been involved with in some of the earlier phase studies.
Sure. I think it's very different than what we've seen just with our endocrine therapy. In using the palbociclib, as you know, about 60% of the patients will have neutropenia, but in the trials at least, the febrile neutropenia rate was very low. So I think that's very reassuring. The other issue with the palbociclib is, I think, the dosing, and a lot of the patients on these trials actually had a dose reduction. I think in both the palbociclib and the ribociclib trial, maybe 30 to 50% were reduced, and then there's a lot of delays. So I think that one needs to be very careful in those first couple of cycles, because it's also a delayed neutropenia that you see. So what I've done in my practice is really checked a white count on day 14, and then that will help guide how to give the next cycle of treatment. And frequently we'll reduce palbociclib to 100 milligrams really easily. I think a lot of people are doing that now. The other toxicities are really minimal with palbociclib, so that's really great. I mean, patients can be on it for, as you mentioned, for 10 months longer than just with endocrine therapy alone. And to me, it's remarkable, and it's really been paradigm changing to have these kind of drugs. And certainly, we don't need to go to chemotherapy at an early time for these patients too, because you have a lot of efficacy in patients with visceral disease. Now, the other drug that you mentioned was abemaciclib. Now, this is a different drug than the other two in that it has more CDK4 inhibitory activity, and consequently, or at least it's thought that the toxicities being different are related to that, possibly because of CDK4 in the GI tract. There's diarrhea as the main toxicity with abemaciclib, and very little neutropenia. And also abemaciclib is given on a daily basis. It looks active in the trial that was presented at ASCO, which was just a straight a large phase 2 study, showed a lot of activity. So I think we'll definitely be seeing more of that drug too. So it's really great that we have 3 drugs that are very active.
Yeah, I think it's very interesting when we look at the mechanism of the bone marrow suppression with the CDK4/6 inhibitors. It's different than what we see with chemotherapy in that it's not cytotoxic to the bone marrow progenitor cells, and that allows for a relatively rapid recovery. It's interesting, you note the dosing differences between palbociclib and ribociclib, which are 3 weeks on, 1 week off, versus the continuous dosing of abemaciclib, as well as maybe the differential effect on CDK4 and CDK6. Ultimately, I think at the end of the day, we could very well have 3 positive studies with 3 different CDK inhibitors, and the question will be, is there really any significant clinical difference? I don't know that we would see a head-to-head study ever being done. There is interest, obviously, in moving these drugs to other stages of breast cancer, as well as in other subtypes of breast cancer. I guess in the United States, we've had this drug approved since 2015 when it received accelerated approval, palbociclib. Dr. Gnant, in Europe, what's the perception of CDK4/6 inhibitors, given they've been approved only recently based on phase 3 data?
Well, I think, it's important to reiterate the excitement about the magnitude of the PFS benefit. After all, this is luminal breast cancer, and the developments so far were based on 3 months difference, 4 months difference. So adding an additional year of progression-free survival is what we have been used to see in HER2-positive disease. But that this kind of magnitude of benefit arrives in the most common subtype of breast cancer, I think that causes a lot of excitement. Now, since a couple of weeks, palbociclib is approved and available in most European countries, and I expect ribo to follow second half of next year. So I think that this is a great thing. By the same token, we have to say that obviously these drugs are very expensive, and it's going to be helpful that there is more than one, I think we have to say, because that's going to assist the healthcare systems in by competition between manufacturers to bring the prices down. And second, we still have some unresolved questions. For example, how are we sequencing these drugs? Can we, for example, use abema in the future after one of the other two? And very obviously, it's also very exciting to consider of moving them to the early breast cancer setting, where if we at least part of the benefit that has been seen in the advanced breast cancer setting could be translated into increase of cure rate, obviously that's an exciting perspective. I have the honor to be involved in the PALOS trial. We have now close to 400 patients recruited in a worldwide collaboration in 25 countries. And other adjuvant trials are going to follow soon.
You gave an excellent discussion today about length of adjuvant therapy, adjuvant AIs. The PALOS study, I guess, is designed for 2 years of palbociclib with endocrine therapy, standard of care. I guess there's a lot of discussion about how much or how long do we need, especially when we see how many unanswered questions there are with drugs that have been around for decades. So we look forward to those results, obviously. I guess, Mark, if you could comment on combination therapy. Is that the standard of care for, first-line, second-line metastatic ER-positive breast cancer based on the data we've heard?
Well, it's such a good question. I think this was elegantly spoken about by Stephen Johnson today in his overview of the talk. And I think I would agree with what Stephen said, that there are patients with luminal A metastatic breast cancer who will do very well just with endocrine therapy alone. So I don't think everyone has to have this combination. But I think for a significant proportion of our patients, that the additional prospect of 10 to 12 extra months on a relatively simple, relatively non-toxic drug, which we can manage quite easily before they need to go on to a more difficult drug, is promising. So I think for us, when we have access to the drug, we will be looking to use it in a significant proportion of the patients who fulfill the sort of trial entry criteria for the studies. Right.
The clinical benefit rate for these compounds for ribociclib, palbociclib is 80%, right? That's clearly a large number of patients that are getting a benefit. And I guess the challenge is we know there's women who do well with endocrine therapy alone. How do we identify who those patients are? And I think some of that was touched on today. Sandra, we now have data that palbociclib and letrozole in the frontline setting is very active. There's data palbociclib and fulvestrant, soon probably approved ribociclib and an AI. Do we start with a combination up front or say, look, if they progress, we can always try a combination in second line?
Well, I think I would agree with Dr. Harries. I see very few patients, when I'm thinking about it, that I would not start on the combination with the CDK4/6 inhibitor and the hormonal therapy. And one of the questions is whether you use the AI or the fulvestrant first, and then, as was mentioned, can you use these again? Is it going to be like trastuzumab, where you continue that and you just change your hormonal therapy or something else like that? So I think those are some of the big questions. And also, really, eventually, I think we can identify patients who don't need the combination. I don't think we have any information now to identify a biomarker that predicts. In fact, you've published and presented some of that data. We don't have a biomarker that will predict which patients will or will not benefit. Right. So being the case that there's such a high clinical benefit of 80% with this really long progression-free survival that we've never seen before in ER-positive disease, I would really be hard-pressed to not give it to a patient unless they were a frail patient for other reasons besides their cancer, for example.
Right, and I think the clinical benefit rate is so high, we're more likely to identify a resistance marker than maybe a better biomarker. So given this dramatic impact of CDK4/6 inhibitors in ER-positive disease, preclinical data also suggests that maybe it would work in HER2-amplified disease. Obviously a crowded space, thankfully, a lot of active drugs. Dr. Gnant, can you comment about potential for CDK4/6 inhibitors outside of ER-positive breast cancer?
Well, I think that these approaches are currently tested in clinical trials, including quadruple combinations of treatment.
Yeah.
Trastuzumab, pertuzumab, CDK4/6 inhibitor plus endocrine. I think that's going to be something like a natural limitation, both in the clinical research setting, but probably even more so in clinical practice. I mean, I share all the enthusiasm, but we still have to realize that in the clinics, and I have hands-on experience with using these drugs in several settings, despite we know that neutropenia is mostly harmless, it's a huge communicational effort. So I receive calls by husbands, by GPs in the middle of the night that, 500 neutrophils and this is potentially dangerous. What are you doing to my patient? I think as a community, we need to be very clear about this, that there is a lot of communications to be done. Also, you were addressing frail patients. There are other patients who may live reasonably far away from the hospital, for whom coming back in 2 weeks intervals to check on their blood count, particularly when this goes on for years, as we all hope, may be a burden. Elderly patients may be struggling with the 3 weeks off, 1 week, 3 weeks on, 1 week off schedule, which is not the case with Abema. However, that's a twice daily thing. So I think some of these very basic logistical issues around the treatment is going to play a role about the uptake in clinical practice. Not taking anything away from our enthusiasm, but I think we need to address this prospectively, very proactively, also in continuing medical education.
So clearly, there's a lot to still be learned about CDK4/6 inhibition. I think the exciting data that's evolved over the past few years has really changed, to some degree, hopefully the natural history of ER-positive breast cancer, which reminds me of a thought that how important, and maybe quickly for each of you, how important is it that we show an improvement in overall survival with this group of drugs? We'll start with you.
Well, it's always such a challenge, isn't it, in metastatic breast cancer to do that. Very few studies have done that because of the plethora of follow-on treatments. And of course, many of these patients who've been recruited into these studies, they might have the opportunity to receive a cyclin-dependent inhibitor, kinase inhibitor in a different setting later on. So again, we might muddy the waters with overall survival. So personally, I think this is going to be a problem for persuading regulators to fund it rather than a clinical problem. I think if we've got the drug and it's benefiting patients, that means they don't need to go on to chemo, then I think PFS is good.
Sandra?
No, I would agree with that, but I do feel very strongly that our goal is survival improvement. And we're not curing patients, at least we don't think, with these drugs because they do progress eventually. So I think we still have to be looking for that endpoint as our ultimate goal. I do agree that this long progression-free survival is really, it's not an artifact. Progression-free survival is a difficult endpoint, but when it's this long, it's real. And delaying chemotherapy is important. So I think it's extremely exciting, extremely important, but survival still has to be the goal.
Finally, Michael, your thoughts on that?
Well, maybe a bit provocative. I don't care any longer about overall survival in luminal breast cancer. These patients, the next generation of trials, we're going to see median overall survival of 60 to 70 months. So even with a spectacular benefit of 10 to 12 to 14 months, this is only a fraction of the lifespan of our patients. Some of these patients will be looking at 6, 7, 8 cycles of effective treatment. So I guess PFS is important. Time to chemotherapy, I think, as you mentioned, is more and more important, and overall survival is going to be increasingly difficult to prove with all these innovations, and it will mostly be used by payers as an excuse not to provide it for patients.
Can I just make a comment? When I meant overall survival, I meant as our goal as physicians.
Of
That's
course.
our goal, not
Yeah, we
as a
wanna save
regulatory
lives.
goal. Because I think
Yes.
for the studies, you're absolutely right.
Well, I thank my colleagues for joining me today on this special eCancer video on the role of CDK4/6 inhibitors in ER-positive breast cancer and other subtypes of breast cancer from the San Antonio Breast Cancer Symposium 2016. I hope you found it useful. Thank you very much.